Okay, guys, we are close to 2:15, and as the schedule suggests, it's time for our second for this conference and first for today, plenary lecture, this time given to us by Dr. Prodanov. So I'm giving the floor to Dr. Prodanov.
Hello, thank you, Peter. I'm glad to be here. Happy for the invitation. It's really nice that you invite me to participate in this conference. I want to give a speech about the contemporary approach in patients with ascending aorta dilatation and to share our experience in our center. I'm working in the University Hospital in Prague, one of the university hospitals there. According to this topic, let me see. Yes, I don't have nothing to disclose. However, those pictures are just to take your attention. This topic is very important because dilated ascending aorta is really a disaster, and the complications that can occur are really can have really catastrophic results, and the biggest problem is, of course, the aortic rupture, which has almost 100% mortality. Doesn't matter if it is in hospital or out of the hospital event. Approximately 50% of the patients with acute untreated ascending aorta dissection die within 48 hours. There are a lot of patients who cannot survive more than these 48 hours, and this is an example of one of our patients who appeared in the emergency department of our hospital with aortic dissection, old, maybe around 1 week older. However, he underwent this operation. We changed the ascending aorta. On the second picture, you can see the dilated and the true and the false woman and after that, we performed the repair of the ascending aorta with a Dacron prosthesis. This surgery was it was an emergency surgery, and we know that almost every fourth patient died, even the surgery. However, if the surgery is elective, the mortality rate is lower, but still pretty high, around 5%. This patient survived, and he was discharged 10 days after the operation. Just a quick pathology overview of the acute coronary aortic syndrome. Acute aortic syndrome that includes the aortic dissection that I already mentioned, the penetrating ulcer, and the intramural hematoma. All the diagnoses are acute and should be treated acutely with and aggressively, of course, because rupture is the biggest problem, and it could end fatal. However, the etiology of and risk factors for the dilation of the ascending aorta are well known. The arterial hypertension is still a diagnosis really underestimated, and according to official data, around 42% of all deaths across Europe are caused by our arterial hypertension. Another reason is the cystic medial necrosis, far not so common. Of course, we should speak about the aneurysms of the aortic root, which are associated with connective tissue disorders like Marfan syndrome, Loeys-Dietz syndrome, Ehlers-Danlos syndrome, and of course the bicuspid aortic valve, which we can of course discuss if this is a congenital heart disease or it is just an anatomical variation. However, 1.3% of the people has bicuspid aortic valve, and very often it is associated with aneurysm of the aortic root. And of course, the last reason, it could be idiopathic, just patients appear with dilated aorta. Just a quick anatomic overview. You know that there is ascending part, aortic arch, and the descending aorta, and the different segments. And generally, we use the classification of Stanford A and Stanford B, depending on the entry of the false lumen and the dissection area, and also the debuggy type 1, 2, and 3. Here is the schema that just to remind you what kind of dissection we can see in clinical practice. The incidence of aortic dissection, according to the Oxford Vascular Study published 2013 in Circulation, was 6 per 100,000 patients per year. But speaking about about the aortic aneurysms, the death rate and the mortality, according to a global burden disease project published in 2010, a very big study with a lot of patients. The mortality is 2.78 per 1,100 patients, which is not so much, but when we see how often or the people are having it and what are the complications, it is still a very severe diagnosis, and we should treat it appropriate. The rate for men and the risk for the men's and older people have increased risk of incidence of this disease. There are a lot of official documents, not only European, but also we're using also the American recommendations for treated, which are describing or setting the cutoffs for and the different methods how to treat the dilated aorta and when to start treating it. The essential part is these seven parameters. The most important thing is to remember this 50 millimeters for the asymptomatic ascending aorta aneurysms. If the aorta is more than 50 centimeters and the patient has no symptoms, we should treat it. Symptomatic aneurysms are always indicated for repair, for treatment. And this cutoff 50 is changing if the patient has a Marfan syndrome or other different already mentioned kinds of connective tissue disorders. Also, patients who are undergoing cardiac surgery because of coronary artery disease and has aortic diameter of the ascending aorta over 45 millimeters should be also treated with repair, or we'll see what we will discuss another option. If the growth rate is also very important, if we have a patient with a aneurysm of the ascending aorta and we are his cardiologist and following him. If the growth rate is over 0.5 centimeters per year, it is also indicated for some intervention, replacement, or you'll see this Pierce procedure that I will speak about. I want to present a clinical case that we were happy to publish in a peer-reviewed journal of cardiothoracic surgery at the end of the last year. I will start with some demographic data about the lady. It was a 39-year-old lady with 3 children. In her medical history, there was anamnesis of intracerebral hemorrhage at her early age. She was aged at 1 year old. In her family, her uncle had a sudden death, no unknown reason. She was pretty high, 185 centimeters, and her weight was 95 kilograms, which makes her overweight, but not extremely obese. At admission, she was on standard antidepressant therapy and some flavonoids, no antihypertensive medication. She was admitted May 2018. On admission, she appeared with slightly elevated blood pressure. The ECG was normal. the laboratory, the D-dimer was positive and the troponin was negative. She went on some funeral ceremony and she had a chest pain. That's why the relatives or her called the ambulance. So at the admission, we performed CT scan, CT angio, where the dilated aortic root and aortic dissection Stanford B. Here you can see on this image from the left side, this is where the dissection starts, the entry tier. And the left vertebral artery originated atypically from the true lumen of the aortic arch as a third branch just before the origin of the left subclavian artery. This is this artery here, which is some malformation, atypical origin. The right vertebral artery was hypoplastic, and the left renal and accessory renal arteries originated from the false lumen. There was kind of ischemia of the left renal arteries. On this picture, you can see the dilated aortic root. We also performed transesophageal echocardiography, TOE, where the aortic root was dilated, 51/54 millimeters. Aortic valve was tricuspid with insignificant central regurgitation jet. On the second image, you can see the intimal flap through the whole length of the descending aorta with a small mobile echogenic structure in the proximal part of the false lumen. However, it was just a wrinkled intima or something. It's not a thrombus. Next couple of days, we wanted to see how first the renal arteries, as I mentioned before, the left renal arteries originated from the false lumen. However, the renal function wasn't altered at laboratory, and the diuresis was normal. So the digital subtraction angiography confirmed the aortic dissection, and the proximal entry tier was localized just after the origin of the left subclavian artery. Distal reentry was on the level of visceral arteries, and the compression of the true lumen wasn't so significant as the CT shows before. That was confirmed by the clinical examination and also the laboratory tests. So the diagnosis of that patient was uncomplicated aortic dissection, Stanford type B, and ascending aortic aneurysm. Because her anamnesis of these hemorrhages, the phenotype of the lady, and the findings on all the imagings that we performed, we asked our genetic department to perform the genetic testing. So Loeys-Dietz syndrome was confirmed. There was an autosomal dominant connective tissue disorder with homozygous mutation. Lady didn't know that. She didn't underwent some clinical tests before that, and she had 3 successful pregnancies, which was pretty impressive with that diagnosis. Of course, something that I should mention is that all the 3 children they have the same diagnosis. 2 of them underwent also ascending aorta replacement in their childhood. However, just quick notes about the Loeys-Dietz syndrome. It is autosomal dominant connective tissue disorder, which was described first in 2005 by Dr. Loeys and Dr. Dietz in Johns Hopkins University School of Medicine in the United States. Main characteristics of this disease are including aneurysms, especially the aortic root is very often dilated. Arteriotortuosity is the third picture on your right part of the screen. Hyperthyroidism, the first picture. Strabismus, split uvula, cleft palate, a lot of skeletal problems. Mainly the patients with Loeys-Dietz syndrome looks like the Marfan syndrome. They're very common. They're very similar. However, the treatment plan at the time of admission was conservative, so we adjust optimal medical treatment. We adjust antihypertensive medication. We performed all those imaging tests that I showed you before, and we discussed the patient on the heart team with a collaboration with angiologists and vascular surgeons. The conclusion of this very long discussion was that we should follow up the patient, and there was a recommendation to try this elective procedure, which is called personalized external aortic root support procedure, or PEERS. If any complication occurs or the size of the descending aorta shows some further progression, thoracic endovascular aortic repair or open surgery should be considered. However, both procedures have their complications. The open surgery has mortality around 50%, and thoracic endovascular aortic surgery, in that case, is hiding the high risk of ischemia of the spinal cord. This is another completely different topic, so I want to get back to the aortic root. And in that patient, we decided to perform this PEERS procedure. She was in the hospital 32 days. She was stabilized. The arterial hypertension was treated. She went at home with four different antihypertensive drugs. Here I want to show us that the collaboration in that case was very important, because at the end this procedure PEERS was suggested for that lady. It is not so common procedure. It is like less than 20 years old procedure. Like, what it exactly means? It is a prefabricated mesh, which is produced in Great Britain by using a 3D plastic former based on a 3D model of images. So we send the MRI, or in that case, we send the CT scans that we had, and they prefabricated this personalized microporous mesh, and we implanted it. This method was introduced in 2004 as a conservative surgical approach for Marfan patients with asymptomatic aortic dilation. However, in recent years, the indication was expanded for different for aortic dilations from different regions. This procedure is very interesting because comparing to the alternative procedures, which we will discuss, it's not the PEERS procedure does not requiring cardiac arrest, cardiac pulmonary bypass, hypothermia, and heparinization. All those things that I mentioned are carrying a high risk of complications during and after the cardiac surgery. Of course, the valve, the aortic valve, we don't touch the aortic valve, so no, there is no need of anticoagulant medication postoperatively. The operation of our patient was performed successfully. It takes like 3 hours, not more than 3 hours. And after 8 days of hospitalization, the patient was successfully discharged. Just a quick information about the conceiver of this PEERS operation. That was this gentleman. His name is Tao Golesworthy. He's an engineer. He is doing some development of combustion and air pollution control and so on. And as you can see on this video, he's very tall, and he has a Marfan syndrome. However, like 17 years ago, he was diagnosed with progressively with aortic dilatation, and the diameter of the ascending aorta was progressively increased over 16 years ago, they said that he should undergo aortic replacement. He was very unhappy with that, that he should receive mechanic aortic prosthesis, and he should take vitamin K antagonist. Here in Bulgaria, it's called Syntrom. In Central Europe, it is warfarin. However, all those medications are the same, and you know well that taking vitamin K antagonist, it's not very comfortable for the patients. There are a lot of interactions, and very often the coagulation parameters are not in the therapeutic window. Very often the patients are over or underdosed. However, this gentleman there was the hypothesis that he can stabilize his own aorta with this microporous mesh. He found investors, he found producers, and at the end he found cardiac surgeon. One very famous cardiac surgeon, Professor John Pepper in Brompton Hospital in the United Kingdom. And after he's the first patient, he received it successfully. They start to debut the project, and they start to present their project, and since then you can find on ResearchGate every half a year he's uploading the current information or updated information about the project. As for 23rd of March 2021, a couple of days ago, he uploaded the last update. There are 439 patients who received the PIERS. Most part of them are with the Marfan syndrome, but as I told you and before, the indication for this procedure is expanded for different for aortic dilatations from other etiology. There are 31 surgical centers around the world who are offering this surgery, this procedure. Interesting is that 7 of them are in Czech Republic. There is a cardiac surgeons in Czech Republic are really interested in that procedure. What are the alternatives? The gold standard of treating aortic root aneurysms and dilations of the sphenic aorta is the Bentov operation, which means, this is the first picture, A here, which means that the patients receive a dacron prosthesis in this part of the aorta. Also, valve sparing operations are pretty common, Jakub and David type operations with the reimplantation of the aortic valve, which means that the aortic valve stays the normal one, they don't touch it. If the aortic dissection progressed through the aortic arch and the descending aorta, the cardiac surgeons are capable to perform the hemi-arch procedures and much more complicated total arch replacement with Carrel patch and elephant trunk prosthesis. However, those operations are really sophisticated. The operation time is really, those are really long procedures, like 12, 15, 20 hours, and they're carrying very high risk of complications for the patient. Just what I just here, I'm holding the dacron prosthesis, and all the mentioned alternative procedures are associated with hypothermic cardiac arrest, cardiac pulmonary bypass, and heparinization. So the PIERS procedure is completely different. That's why the first question that I'm expecting from you is what evidence we have, and if there is a randomized clinical trials. No, there are no randomized clinical trials, and the reasons are first that it is not possible to perform it, because if we should compare peers with optimal medical treatment versus only optimal medical treatment alone, it is not possible, because you cannot make a blinded trial. To compare peers versus replacement is pretty difficult also, because those patients who are receiving peers procedure are receiving it earlier in the stages of dilatation of the ascending aorta. And the replacement, as I showed you before, according to the current guidelines, is indicated only in patients who have the ascending aorta over 50 millimeters. And the nature of the operation is completely different than the replacement of the ascending aorta. So it is like comparing pears and apples, they said in a couple of presentations. Of course, if you should compare peers procedure versus doing nothing, there is an ethical question. And for the last 16 years, we know that patients who receive peers they have some benefit. So the ethical question still stays, and all the patients will choose after a very detailed discussion with them. They are always agree with this peers procedure. So there are a lot of every country which accepted this method is doing this observational study. That was our first patient that I presented to you, and we're still following her, and we have a couple more patients, and we're also doing this observational study with them. We discussed that with our ethical committee and so on. So still the results, that lady appears in our hospital 2018, and she's still alive and feels pretty fine. Why there is no randomized clinical trial? There was a very interesting article published in 2020. If you're interested, you can find it. They are discussing exactly the same things, why they cannot perform RCT. As a cardiologist who is working almost 3 years in the cardiac surgery, I see that especially the cardiac surgeons, but the situation is same in the general surgery. There are not enough controlled clinical trials, and most surgical trials are conceptually hindered by factors including surgeons' preferences, operative expertise, source of funding, referral pattern, selection bias. It is very hard for the surgeons to understand that it is essential, and it is very hard to organize randomized, double-blind, and so on clinical trials for all those surgical methods. For example, Jakub and David procedures, which are very old, are also nobody performed randomized clinical trials about them. And over the last 2 decades reveals that less than a half of the surgical treatment recommendations could be addressed by randomized clinical trials. It is a study which is, I'm citing here a study which was published 1995, but the situation is pretty same nowadays too. However, 2000 from the beginning of or what is important for this procedure, that we don't have clinical randomized clinical trials, but however, a lot of institutions or the producers are received confirmation, and mainly because it was designed in the United Kingdom. So many institutions approve the procedure after presenting the data from the big cardio centers in United Kingdom. What is interesting is that they still wait for approval from the US Food and Drug Administration, where the Pierce procedure is not still available. It is available in all over the world, but not in the United States. Another question that I'm expecting is what is the price? I'm not here to sell this product, but just want to say that the expenses when you have a patient who underwent ascending aorta replacement are in critical condition after the operation, and stabilization of those patients are really expensive, and the procedure the price of the procedure is maybe higher. I mean, the price of the Pierce procedure is higher, but the whole hospitalization is definitely not so expensive as for patients who underwent acute operation because of aortic dissection, for example. So let me get back to our patient. This is CT angio, which comparing the parameters before and 14 months after the procedure, which shows, and this image shows that there is no further progression. We are still following this lady, and the aortic root is the same diameter. There is no progression, and it's stabilized, and happily the descending aorta is also stable and doesn't make we don't see any further dilatation. This is the what I mentioned before, the descending aorta. There is a slight progression of the diameter, but however the trumen stays untouched, and as I mentioned, the operation of the descending aorta is with around 50% of mortality. So we prefer to follow up the patient, and if some further progression appears, we will discuss what we will do with her. However, the most important thing that I want to remember from this clinical case is that it's very important, the multidisciplinary approach, especially in those kind of complicated patients. In cardiovascular disease, the heart team is something essential, and the collaboration with different specialty is very important. Multimodality imaging, if available, is also very important, because there is no imaging method that is perfect, and not only the one image is important, but also the function of the different organs. As you see in that lady, we see that there was a dissection and the compression of the trumen on the compression of the trumen. However, on the digital subtraction, the digital subtraction angiography, when we see in motion what happened, we see that the compression wasn't so significant, and the aggressive research for evidence is really important for a lady, and even when you cannot rely on randomized clinical trials, you should always search for some evidence when you use new methods. Thank you for your attention. If you have some questions, I'm staying online. Peter? Peter?
Yeah. Well, I was with my microphone off. Sorry.
Okay.
There is a message in the chat by Dr. Prodanov, who says, thank you, Dr. Prodanov, for your wonderful presentation, sharing your experience. What do you think? Would it be useful to test her relatives, children, for that genetic connective tissue disorder, and can some kind of prevention be applied?
Yes,
if the diagnosis is
all
confirmed?
the kids were tested, and all the kids are positive, and they have this Loeys-Dietz syndrome, and two of them underwent ascending aorta replacement, and the third one, the youngest one, we discussed with a pediatrician, like a cardiac surgeon for kids, that maybe he will underwent also this Pierce procedure in early age. It is not approved. It is not approved still for young kids. So we are waiting because further discussions are undergoing now. But probably he will receive this Pierce procedure.
Okay, thank you.
Okay.
Other questions? I'm keeping an eye also on the chat.
Okay.
Well, thank you for this fantastic presentation. If there are no other questions, then we will resume again at 3 o'clock, which is exactly after 10 minutes, with the last session for today, which will be pharmacy and pharmacotherapy. And after that, we will have our third and last for the conference plenary lecture given to us by Dr. Yelutchkov. So a 10-minute break now, and see you again exactly at 3.
Okay, thank you.